managing or dealing with anemia, is that as a cardiologist, I'm not have expertise in this area, but it's such a common problem. For instance, almost half people who are relatively elderly who have congestive heart failure have some degree of anemia. If your kidneys not working properly, you probably have some anemia. So, and one of the questions people ask me, just give me an iron pill. It's not that simple. So we're going to actually figure out, first of all, what anemia is and some ideas about that. Take it away, everybody. I'm really excited about this one.
Of course. So before diving into what anemia is, let's go over some important terms to know. So first one would be hematocrit, which is just referring to the volume percentage of red blood cells in the blood. So it's just like the ratio of the volume of red blood cells to the total volume of blood in the body. The next one would be hemoglobin, which is the iron-containing protein in red blood cells that allow the cell to transport oxygen throughout the body. So now going into what anemia actually is defined as the reduction in the hemoglobin concentration of the blood below normal for age and sex. Another way of putting it is just that an individual lacks enough healthy red blood cells to carry adequate oxygen to the body's tissues. So the normal range for the normal hemoglobin range for males would be between 135 to 175 grams per liter. For females, it'd be 115 to 155 grams per liter, but it's also important to note that these values also decrease with age and throughout adulthood. And for hematocrit, for males, it's usually between 38.3 to 48.6%, and for females, it's 35.5 to 44.9%.
So you can see that it's not the same for both males and females. It's the red cells. That's it gives what gives your cells that red color to them. I guess if you're a Vulcan from Vulcan, you have blue blood, but we have red blood from hemoglobin, the red cell mass. And so again, is that very interesting to realize. I didn't realize that when I first started, it was different than males and females. And also as you get older, it falls a bit. So that's very interesting. So I learned that quite a few years ago, and so very important. Thank you so much. Keep going.
Awesome. So when it comes to low hemoglobin count, when you have chronically low hemoglobin counts, this typically points to chronic anemia, and individuals with anemia do not receive enough oxygen-rich blood to their tissues. And so the heart compensates for this by pumping faster to increase the flow of blood. And eventually this can lead to cardiac remodeling or cardiomegaly. And this is the enlargement of the heart. And eventual heart failure, unfortunately. And anemia can also cause an increase in erythropoietin or EPO production. And so EPO is just responsible for telling the body to make red blood cells. And anemia can also cause increased oxygen extraction. So for those who are anemic, they have an increased need for oxygen. And so their tissues extract more oxygen than the blood actually delivers, which ultimately leads to decreased venous hemoglobin saturation and a lower tissue oxygen saturation.
So the first message is that your hemoglobin, it responds to different forces in your body. One is erythropoietin. This is a substance secreted by the kidneys to produce more red blood cells. And so one thing, if your kidneys don't work, then you can have anemia due to kidney failure, for instance. Also, too, that we know that people who, that's what athletes do, they train at altitude, is that you deprive yourself of oxygen, and you exercise more, your body will, thank you so much. It's good to have good hot soup, so I have, so I hope everybody, when you have the videos, that you have something to eat. So I have this vegetable soup. It's full of some kale in there and some spinach, and just a vegetable soup with some ginger there. So, and we'll talk about whether or not this soup has actually any binding iron in here too as well at the end there. So and so getting back to the webinar, is that you can see that your hemoglobin is determined on if you exercise, for instance, if you have enough oxygen, your kidney function, and we're going to learn that there's so many different causes of your red cell mass, and see what to do about that. So keep going on.
Awesome. So as mentioned as well, so a low hemoglobin count doesn't always necessarily mean it's a bad thing. Some sudden drops in hemoglobin can be accounted to blood loss, such as internal bleeding, such as in your intestines, or hematochezia, which is just bloody stools. frequent blood donations, heavy menstrual bleeding, and also those who are pregnant tend to have a lower hemoglobin count as well. But it's also important to know that these can be regulated back to normal levels. So some signs and symptoms of anemia usually include shortness of breath, pallor, weakness, headaches, and some cardiac symptoms, including heart failure, palpitations, and angina. And so when you have faster onset anemias, they tend to cause more of these symptoms to show up in a patient than slower onset ones. And so here are these values here, just underneath severity, it just mentions kind of what describes mild, moderate, severe anemia. And as also mentioned before, age, as we age, we're less tolerant towards anemia because of the decreased amount of hemoglobin and hematocrit.
So it's kind of interesting, the slide over here is that, so this is one of the traditional thinking is that you can have, some anemia be totally asymptomatic, but you can also actually have a normal hemoglobin being deficient and still be short of breaths. The reasons for that is iron is certainly involved in red cells, but it's also involved in other pathways in the body as well. So one of the things that I've learned recently is that you can have a normal hemoglobin, still be iron deficient, and still get short of breaths. And we'll explore that a little bit later too as well. But traditionally is that the degree of anemia tells us severity of symptoms as well. And that's absolutely true as well. So we have to counter those factors as well. And what I hope we walk away from this is that anemia is not just a problem of iron. It's much more complicated than that. So keep moving forward. Thank you so much. And you can be short of breath for all sorts of reasons. I can be deconditioned, I can be overweight, I can be depressed, I can be in congestive heart failure, I could have bad lungs. There's all sorts of reasons. So anemia is just one cause. And as we get older, we have more chronic diseases, we can have multiple causes why we're maybe short of breaths.
Great, awesome. So as Dr. Kearney mentioned, so this just might be a thought that we have. If I develop anemia, then I guess I have to start taking iron supplements. And as Dr. Kearney mentioned, that's not always the case. So if we check the next slide, we see here that there's actually various different types of anemia. And these can be classified by something called the mean corpuscular volume, which is in essence just the average size of your red blood cells. So it can be broken down into three main categories, the first one being microcytic anemia. So this is when your red blood cells are too small or less than 80 FL. And this leads to ineffective transportation of oxygen throughout your body. And it is most commonly caused by things like iron deficiency, but also something called thalassemia. Normocytic is when you have anemia, but the size of your red blood cells is in the normal range, but the concentration of it is low. This type can be further broken down into hemolytic and non-hemolytic anemia. Hemolytic anemia is more common and occurs when your blood cells are killed off faster than they can be produced. And there are many factors that can cause this, but is most commonly caused by chronic diseases such as kidney disease, cancer, rheumatoid arthritis, and other diseases as well. Meanwhile, non-hemolytic anemia is relatively quite rare and happens when the body stops producing red blood cells, which we'll get into a little bit. It's called aplastic anemia. And there are congenital diseases that can cause this, but is normally observed in early developmental stages of chronic illness before hemolytic anemia also sets in. And lastly, we're going to talk about macrocytic anemia, which is where your red blood cells, as you might have guessed, are too large, so greater than 100 FL. And this type can be broken down into megaloblastic and non-megaloblastic anemia. And megaloblastic anemia refers to anemia caused by a genetic mutation, which can affect the absorption of vitamin B12, vitamin B9, and the folate pathway. As well, non-megaloblastic anemia is caused by external factors, which can include things like alcohol, liver disease, and so on. So it's important to understand that when we're talking about anemia, it's not just something where we're talking about iron, although that is a main component of some anemias.
So that's actually important. So the first thing is that they were making doctors out of everybody today. And so the classification is, what your hemoglobin is. The second, what's the size of the red cells? Are they normal size? Means that the MCV between 80 and 100. Or are they small, less than 80? Or are they greater than 100? Now, you can have a mixed pattern of multiple types of anemia too as well, but this is how most medical people think about how they classify anemia, and this is how you should be thinking about that yourselves. Go ahead, tell us more.
Yeah, so on those lines, we're going to go into a little bit about diagnosing anemia. So as I mentioned, there are various causes of anemia, and we're just going to give a brief, more in-depth overview of just the main ones. So first we have the iron deficiency, which is the one that we're all typically more accustomed to, and it is the most common cause of anemia. And this can occur for different reasons, including pregnancy, blood loss, or an inability to absorb iron. We'll explore this topic a little bit later on, but this is just a good intro to understand that. Again, understanding that it's a microcytic, or your blood cells are too small. Thalassemia, also microcytic, where your blood cells are too small, is caused mainly through congenital diseases, so your genes. And there are two types of mutations that can cause this, and these are typically within the alpha and beta chains of the hemoglobin. And for the beta chain, you only need one mutation, but for the alpha chain, you need two. So it's a little bit, this is more something that is diagnosed by your doctor, and as I mentioned, is a little bit more genetic in that nature. Now we're going to move into sickle cell anemia, which is something you might have heard of. It's where your blood cells, instead of being that nice round shape, it's these jagged sickle-like shape, as you can see in this photo here. This is again caused by the inheritance of a mutated gene from a parent, and it can provide 90% protection against malaria. However, if two copies are inherited, then it produces defective components in hemoglobin molecules that can cause them to malform, and this can cause them to be ineffective transporters of oxygen, as well as also become sticky and rigid and cause blockages and slow down blood flow throughout the body. There's also renal disease, which we'll get into a little bit more later on, but that's when you have problems with your kidneys and reduced erythropoietin production, as Dr. Kearney mentioned, which is important for the production of red blood cells. And the last one we're going to talk about is aplastic anemia, which is where your body stops generating red blood cells and can consist of both normocytic and macrocytic. So your blood cells might be the normal size, or they could also be enlarged as well, or a mix of the two. And this can be caused by things like radiation, chemotherapy, or exposure to toxic chemicals or viral infection. So here, I guess, as Dr. Kearney said, we're really about helping you understand kind of how this process works out. So there are three main tests that we can do for diagnosing anemia, and going from 1 to 3, they get a little bit more invasive as we go. So typically, we'll start off with something called a complete blood count. So what this is it's the measure of the total number of blood cells and other important markers in your sample of blood. And it'll measure things like hemoglobin, the red blood cell, or the hematocrit, the iron levels, and the transfer capability. So something that we might order is ferritin and transferrin saturation, which we'll talk about later, and the white blood cell count. So these are making sure that we're looking to see, are your values within the normal ranges? And these can be done relatively easily, as when we give you those blood requisition forms when you come for the visit. Typically, you might see a CBC checked off, and that's what we're looking at. The next thing is called a blood smear. And so what they do is they take a thin layer of blood and they smear it across a piece of glass, and they use a microscope to stain it. So as you can see here, I put a little a comparison for you on the right. So on the top, we see a normal blood sphere. So what we're looking at here is we're seeing that those nice looking red blood cells, they're nice and uniform in shape, nice circular, and they have a nice central pallor, or that little white center part, and it's about 1/3 of the diameter. But when you're looking at the iron deficiency, or the microcytic anemia that we're talking about, you can see that some of the red blood cells are abnormally shaped, and compared to the size of a lymphocyte here, you can see that they're actually smaller than they should be. Sorry, did someone have a question?
No, we're good. Fire away.
Okay, perfect. Yeah, so that's what you can see from a blood smear. And the gold standard And this is typically only done for anemias that may or may not be misunderstood, or things that might be looking like it's aplastic anemia. These are going to be cells that are isolated directly from your bone marrow, and typically is a little bit more invasive, and which is why you're less likely to actually see that in general practice.
So it's important to know this. Good point. So it's sort of like a detective story. So we're giving you all the different, who are the potential villains, why you might have a low red cell count, and then you have to put it together. So, and again, as you point out, Matthew, the gold standard is a bone marrow. When you're not sure, a bone marrow can be helpful. So, if, for instance, if your bone marrow is not working properly because it's invaded with something called multiple myeloma, a cancer cell, then you need to do a bone marrow to find that out. And sometimes we're not sure what the iron stores or other stores are. Sometimes you need to do a bone marrow. Most of the time, you don't need to. These are things that you have to decide. And obviously, when you're at that level, you're speaking to a specialist in this area, such as a hematologist who's an expert on these diseases. So that's the range. Thank you for showing that. So you can have a smear where where a technologist or the doctor looks under the microscope. And it's not something I do at this stage in life. I did that in medical school, but you don't want me to look at your smear right now. I'd be the wrong person right now. So lots of things to learn from a simple blood count to look in the microscope and to actual bone marrow. A piece of bone tissue is removed inside the marrow to look what's going on. Thanks a lot. Yeah, so I keep saying this, and I hear this almost every day. I'm anemic. Just give me some iron, doctor. Next slide, please. And I hope you realize that there's multiple causes. And here's how I think about this over here. Is that Matthew talks about is that it really depends on the cause. So classify things by the degree of anemia. Number two, the size of the red cells. So Matthew talked about nicely about thalassemia, iron deficiency, but there's other causes too, from lead deficiency, thalassemia, anemia, chronic disease can cause something called cereblastic anemia. You can see that size of red cells, the first thing I think about is their alcohol, but this could be liver disease. It could be that the bone marrow is not producing, or you're producing a lot of red cells, and the new red cells have a bigger size. And of course, we'll mention things like folate deficiency, but it's pretty rare in North America because of supplementation. But B12 deficiency in people that are pure vegans are an issue. And of course, anemia is a chronic disease. Certain diseases of hormone problems such as kidney failure or something called Addison's disease, or even early iron deficiency can give you a normal NCV2 as well. You can see it's pretty complicated. I have a basic understanding of this, but this is not my area of expertise in that. I'm not sure if in the group, this is a slide that, or this is something I keep in my back pocket sometimes to look at when I try to investigate this. But clearly, if you have a serious anemia, it doesn't is that I can't always make that diagnosis, and sometimes need some help. Your family doctor, people in internal medicine, the gym rat clinic, hematologists, cancer doctors. Often, it can be pretty complicated. So the answer is that iron is not going to be helpful for many types of anemias. Anything else anybody want to say, or and we're going to go this in a lot more detail, but I just want to show you how the brain looks at these sorts of things, or how a doctor might look at this. Fire away.
Yeah, thanks, Dr. Curnew. And just kind of to underscore that point, I just wanted to put up this visual. It's kind of I know it looks very daunting, and it just kind of shows us the complexity of anemia and where we're going in terms of the different tests we can do, the different causes. If someone responds to certain medication in a certain way, then does that mean that they have, that we're treating the underlying cause? So there's so many different areas to go with anemia that it's really important to make sure that we're getting that regular blood work, we're monitoring our symptoms properly, and as Dr. Curnew mentioned, we're being very transparent with both with all the doctors in our care, whether that be an internist, whether that be a cardiologist, or that be our family physician. All right, so now we're just going to touch on some risk factors that might increase your risk for developing anemia. So the first one we're going to talk about is the kidneys. The kidneys are very important for clearing out things in your body, but they're also really important for red blood cell production. So as we mentioned before, the kidneys are responsible for releasing erythropoietin, which is done so in response to conditions of low oxygen, whether that be, obviously if you have, when you're in higher elevations, you might need more of that erythropoietin. So low oxygen means that we aren't able to carry adequate amounts of oxygen in the blood, meaning that the kidneys are picking up on that lack of hemoglobin and encouraging the production of more red blood cells. And this is a very normal process and happens in everyone. Our red blood cells only have a lifespan of around 120 days. So whenever it's time to produce more, the kidneys will kickstart this process to make new ones. The EPO released by the kidneys stimulates the bone marrow to make more blood cells and increase our ability to actually carry that oxygen. But the difference is healthy kidneys are able to detect that we need more red blood cells quite well, in fact. However, damaged kidneys don't send out enough EPO to keep up with the needs of our body. And when we don't have enough EPO, you guessed it, we're not going to have that same red blood cell production, which means we're going to end up with inadequate levels of red blood cells and the hemoglobin that they carry. So certain conditions can put you more at risk of kidney dysfunction and therefore more at risk of anemia. So things like excessive blood sugar, which can be caused by diabetes, specifically type 2 diabetes has been something that's been linked with chronic kidney disease and anemia as well. And high blood pressure can all result in damage to the kidneys, ultimately increasing your risk. The next thing we're going to talk about is actually an interesting one. It's about testosterone. So testosterone, there's been some studies, for example, one that studied 905 men and women that were over the age of 65 and found that patients with low bioavailable testosterone levels actually had a 3.9 times greater risk of developing unexplained anemia, so anemia from unknown causes. And also, another clinical trial found that 54% of patients with unexplained anemia randomized to either receiving testosterone gel as a supplement or placebo, they found that they found that actually 54% of the patients with the testosterone gel had greater than 1 gram per deciliter increase in their hemoglobin levels compared to just 15% of the placebo. And as you can see here on that graph, that was quite significant. So it suggests that having these low levels of testosterone might increase your risk and could be beneficial to do some testing and bring up with your family physician if necessary.
It's also true that as people who take testosterone can actually have too high a hemoglobin and actually increase viscosity of their blood and actually lead to stroke. Testosterone is a very controversial area, and to me, there's some data that testosterone may increase the risk of heart disease, and there's some data it may not. I worry we got women's hormones wrong the first time around, and so we know that estrogens do increase risk of getting a heart attack or stroke, increase risk of breast cancer. Testosterone may improve your quality of life, but it also may actually increase your risk of getting a heart attack and increase the risk of prostate cancer, and it thickens the blood. So it's part of that equation to look at. So I'm a little bit leery about testosterone supplementation, but you'll get different opinions from different people about that one. Thanks for sharing that.
Yeah, it's definitely one of those things where it's like a fine balance, and obviously depends on who you talk to with that. Something we're going to talk about as well is vitamin B12 and folate, which are both B vitamins, and the deficiency of those can lead to the abnormal development of red blood cells. So when we see that we're lacking in these vitamins, then we find that we actually start to produce abnormally large and oval-shaped cells as opposed to the nice normal-sized flat biconcave discs shaped cells that we're looking at. And as a result, there's fewer cells that are produced in the bone marrow, and some studies have shown that in some cases, the red blood cells for people with vitamin D and folate deficiencies may actually have a shorter lifespan than those that are produced normally. So again, some symptoms of vitamin B12 deficiency. You can see that mild are similar to those of anemia, where we have fatigue, headaches, and weight loss. And then severe is more like impaired balance, muscle weakness, and mood changes. So it's important to make sure that we're getting enough of these, especially as Dr. Kearney mentioned, if we are subscribing to a vegan or vegetarian diet.
This is actually very important. So is that B12 deficiency could be a autoimmune process. So you may not be absorbed B12, or it could be a nutritional effect too as well. So if you're vegan or plant-based eaters, you should probably get a B12 level about once a year or so, because if you're B12 deficiency, you could actually cause neurological damage. So you can actually damage your neurological system. It can not just the anemia part, but just nerve damage as well. So thanks for sharing that.
Yeah, and in that sense, I just wanted to give you these are the recommendations from the American Association of Family Physicians, and they recommend vitamin B12 screening. So again, that's something you can talk to your doctor about, and they can add it to your blood test. They recommend it for screening for patients who have inflammatory bowel disease, which is something that we've done a webinar on before. So feel free to check that out as well. Gastric or small intestine resections, because these could inhibit the absorption of vitamin B12. Metformin use, which is used for diabetes. And if you're using it for longer than 4 months, it's recommended that you get screened as well. Proton pump inhibitors or histamine H2 blockers. You might know these because they're very common heartburn medications, so like pantoprazole or ranitidine. And if you're using that for greater than 12 months, those people who are vegan or strict vegetarian diets, and those who are over the age of 75. So if these apply to you, it might be beneficial if you haven't checked your vitamin B12 to ask for that, or talk to your doctor about whether or not you think that's a good fit.
So it's important. So if you have ulcerative colitis, Crohn's disease, you've had bariatric surgery for weight reduction, these are some of the things that you need to think about. And it's one of those things that I don't think enough about because it's not my area of expertise, but something I need to talk about. So next time you see me, for instance, if you feel you need to have this done, so the first clue is that you have one of these processes, or you're taking, let's say, metformin, or you're taking this bad gastritis inflammation on my stomach. I take these PPIs, such as, let's say, Periot or Pantaloc, Nexium, Losec. You're taking them on a chronic basis, that's fine. Also, if you may not need to take these medications anymore. So you had like a lot of reflux pain before, a lot of acid pain that got better. You lost 20, 30 pounds. Talk about, we can actually think about stopping those medications as well. So those are what I think all the PPIs are groups of medications that are treated for reflux, for symptoms, and also in some people who had bleeding ulcers, and sometimes you need them for the rest of your life, and sometimes you don't. So it's an individual decision. So that's a medication you can talk to about that, and remind all your doctors, maybe I should get a B12 level. We can talk whether that's useful. Thank you for sharing that. I didn't know all these things, Matthew. Thank you.
Yeah, it's always good to have these webinars, because we, in doing the research, we unearth a lot of things that are good to spark up some conversations. Speaking of which, we're going to talk about how can we get vitamin B12. I know we've talked a lot about it, and there are typically 3 main ways that we can get that. So one is to go to start eating more foods that are naturally high in vitamin B12 or folate. So these can be things, vitamin B12 is typically found from animal products, again, which is why we advise people who are vegan or vegetarian to have these other fortified foods. But these are things like yogurts, fish, eggs, beef, or chicken. So seafood actually has a lot of vitamin B12 as well as omega-3s. There's actually I think a cooking demonstration, cooking with a group of us at the clinic on Sunday, if you want to join that as well for the people who are here.
So those who want to, we have Didi's a fantastic cook, and this Sunday we're going to do seafood beyond fish, and basically it's 4 to 6. So if you're interested, just send in at drkearney232@gmail.com, or and we'd love to include you. So it's a fun thing. I love these things. We do that about once a month or so, and great talk, great time. Thank you.
Yeah, so that's a great way of getting vitamin B12. Another way actually to get vitamin B12 is nowadays, especially in developing countries, we have a lot of foods that are fortified with B12. So things like cereals, tofu, and also milk alternatives. So there are things like soy milk, almond milk, rice milk, oat milk, things like that. Typically, you'll see that they can be fortified with B12, vitamin D, stuff like that, or folate, which are ways that you can help increase your intake without actually having to, eat meat or eat those meat products as well. That's really important to make sure, especially if you're vegan or vegetarian. And lastly, there's vitamin B12 and folate supplements that you can take. So orally, you can take those supplements over the counter, but it is recommended that you talk to your physician about that, just to make sure that there's no contraindications, and it's advisable for your individual needs. Okay.
So it's important if you're vegetarian or vegan is that if you buy nut milk, let's say you buy oat milk, soy milk, or whatever you have that's fortified with vitamin B12, or if you have nutritional yeast that's fortified with B12. So always just make sure that's what you're buying. You want to get some B12.
Exactly. And you also want to get folate. Interestingly, actually, folate deficiencies are very rare in developed countries, as I mentioned, due to fortification of different things like grains and milk. What I guess would cause some folate deficiencies? Well, they found that actually a lot of people who suffer from chronic alcohol use will actually have decreased absorption of folate in the small intestine, an abnormal uptake of folate and storage in the liver, as well as increased urinary excretion of folate, which actually shows that the incidence or occurrence of folate deficiency is actually quite higher in people who have chronic alcohol use or alcohol-related illnesses compared to those who abstain from alcohol or those who are considered healthy without those alcohol-related illnesses. As you can see down here, a study of 70 chronic alcohol users found that over 80% of them actually suffered from folate deficiency. Meanwhile, the prevalence was 11% in those with alcohol-related illness compared to only 5% of the population in healthy adults. Now we're going to talk about SGLT2 inhibitors. So these are a very commonly prescribed medication. So as you can see on the next slide, they're typically used to treat type 2 diabetes, and they help by reducing glucose or sugar levels in your blood. And they do this by increasing the amount of sugar you pass in your urine. So you might know these because you've been prescribed them either by Dr. Kernew for your diabetes or NCHF, or by another professional. And these can include three main ones called Invokana or canagliflozin, Forxiga, epagliflozin, or Jardiance and pegliflozin. And as you can see here, this on the right is an image of something called a nephron, which is really just the functional unit of your kidney. And we can see here that it says predominantly SGLT2, about 90% of the glucose is reabsorbed through that channel back into your blood. So what we're doing is by inhibiting that reabsorption of glucose, we're allowing it to be excreted in the urine, allowing us to reduce our sugar levels. But how does that work with anemia? Because as you know, this is an anemia webinar. So on the next slide, we see that there's this thing called the Credence trial. And so what the Credence trial was, it was a large study of over 4,401 patients. And they were patients who had type 2 diabetes and chronic kidney disease. And as we've noticed, we know that this population is at an increased risk for developing anemia. In a mean follow-up of 2.6 years, at 1 year, the patients who were on the SGLT2 inhibitor, canagliflozin or Invokana, had a noticeably greater hemoglobin, hematocrit, erythrocyte concentration compared to those who received the placebo. And overall, they found that there was a 35% reduced risk of anemia diagnosis and treatment in patients who were on the SGLT2 inhibitor versus those who were not on the SGLT2 inhibitor. And you can see that graphically presented on the right, where we see that the mean change in hemoglobin was actually higher than, the mean change was lower in the group that got the SGLT2 inhibitors compared to those who did not. So it shows that being on these medications can actually, in addition to helping you with your diabetes, your blood sugar levels, can also help potentially with reduce your risk for anemia.
Well, that's actually kind of important to realize. The Credence trial was a trial with people who had damaged kidneys from diabetes. And we mentioned that damaged kidneys can't secrete erythropoietin, and therefore you have more anemia. So this trial actually shows that these categories of medications do increase erythropoietin-like products, and they increase your hemoglobin. So it's remarkable. So it's interesting. These drugs were initially just used to lower blood sugar, but the blood sugar lowering is the least important part of these drugs. What they do is actually they decrease end-stage renal disease failure by 40%. They decrease hospitalizations for congestive heart failure by 30%. These mechanisms are totally independent of its blood sugar lowering effect. You can see they also improve hematocrit, hemoglobin as well. These are just some of the, so this is something to think about. And this is something useful. If you have bad kidneys, you often get something called the erythropoietin, but you can also use these drugs too to actually boost your hemoglobin too as well. So thanks for sharing with us.
Yeah, and this next slide is just a good summation of all of the studies that have been done on SGLT2 inhibitors. So it's actually something called a meta-analysis, which kind of it's like a study of studies where it included 4 different studies and a total of 19,259 patients, like Dr. Kernu said, with chronic kidney disease and type 2 diabetes. And they ranged from different interventions, so both empagliflozin as well as canagliflozin, so 2 different types of SGLT2 inhibitors. And across those 4 studies, they found that there were moderate effects for both increasing hemoglobin as well as hematocrit. And overall, this suggested that SGLT2 inhibitors can significantly increase both hemoglobin and hematocrit at all dosage levels. And these also suggest that SGLT2 inhibitors as a whole, not just Invokana, can reduce the incidence of anemia. So just something important to know if you are taking SGLT2 inhibitors. And now we're going to focus on iron deficiency anemia. I know we've talked a lot about it, but we're just going to go into a little bit more depth just because it's so common and something that a lot of us might struggle with. So just going into it, it basically is results when we have insufficient iron stores in our body. And hemoglobin, this really important protein we've been talking about, why is it called hemoglobin? Well, there's this thing called the heme protein, and heme means iron. So at the center of each of these heme molecules, we have an iron, which is why low iron leads to low hemoglobin. There can be many potential causes, not just the lack of iron, but this can be something called, it can be caused by blood loss. It can be a lack of dietary iron, so we're not eating enough iron. It could be an inability to absorb iron, or it could be caused due to pregnancy, due to the creation of more and more blood cells to provide oxygen for both the mother as well as the fetus. And as we've said before, there are certain individuals that are more at risk, and these include women, infants, and children, vegetarians or vegans, as well as frequent blood donors. So you might be asking, how do we test for an iron deficiency? So what we do is we look at something called ferritin and transferrin saturation. So to start off with the ferritin blood test, this test measures the amount of ferritin protein in your blood. Now, ferritin is a blood protein that contains iron, so levels lower than normal might indicate that you don't have enough iron in your body. The normal range for this is anywhere from 24 to 336 micrograms per liter, while the normal range in women is lower at 11 to 307 micrograms per liter. And anything below the normal range indicates you might have iron deficiency anemia. Transferrin saturation, on the other hand, is another different test that can tell us about iron levels. And it it's pretty much the ratio of the amount of free iron in the blood that isn't bound to anything compared to the amount of available transferrin in the blood. And the main protein, it binds with iron in the blood, and the test, since it's based off a ratio, its values are reported as percents. And this means that a transferrin saturation of 15% is equivalent to having 15% of available transferrin bound to iron versus 85% still open to be bound. The normal values are not dependent on the sex of the individual, unlike ferritin, and getting the test done is like getting ferritin and hemoglobin, can be done through a blood test. Anything between 20 to 30% is considered normal for women, while anything between 20 to 45% is considered normal for men, and levels below 20 indicate iron deficiency anemia, and anything above 50 can indicate excessive iron stores. These are just two tests that we might order. Again, you can see this on a blood requisition test that we might order for you. And if you see that, then you know that we're trying to look at the iron levels within your blood.
Now, it's quite interesting that if you just go back one slide there, that ferritin has a very large range between 11 to about 300 in males, 20 females, and 20 to 300 in males, which is very, very, very. It's a huge range. It makes it confusing. Ferritin is a marker for iron stores. It's also a marker for acute phase reactant. So if there's inflammation going on, let's say you have congestive heart failure, you're overweight, you have diabetes, you're having a pneumonia, you're sick, you have certain cancers. This all causes inflammation to take place, and it can falsely, or it gives it an elevation, but it's not a reflection of iron stores. And so it's a detective work, and it's not always so simple. And I think, Matthew, you showed some really nice numbers. Tell us more.
Yeah, so what we're going to talk about now is actually as Dr. Cooney mentioned, the complexity of it. There's a wide range of different criteria for what is considered iron deficiency. The international guidelines suggest that it's a ferritin less than 100 nanograms per milliliter, or transferrin saturation of less than 20% if the ferritin is 100 to 29 nanograms per milliliter. However, different papers, different hospital systems, different doctors may consider iron deficiency anemia by different metrics. So for example, some might just say it's ferritin less than 100 nanograms per liter. Some might say it's only the TSAT of less than 20%. And some might say it's the serum iron of less than or equal to 13 millimoles per liter. So there's a lot of different ways, there's different metrics. As you can see, they're not even the same units oftentimes. So it's really important to understand that although we say that there's a very hard, rigid guidelines and cutoffs, oftentimes that's not the case. And that just leads to even more difficulty diagnosing and oftentimes treating anemia from provider to provider. Okay, I'm just going to pass it off to Kian, and he's going to talk about some secondary conditions associated with iron deficiency anemia.
Yes, perfect, Matthew. Can you hear me? Yes?
Yes, you're good.
All right, perfect. So far we've discussed all things iron. Now, specifically for iron deficiency, we also see some secondary conditions that could result as a result of anemia. Now, there's way more than this, but we just wanted to highlight a couple, especially some that have been missed by prior physicians and also individuals. So one thing that's really interesting is restless leg syndrome. So anemia has actually been linked with restless leg syndrome. Specifically, low iron levels have been associated with reduced dopaminergic activity. And what this means is basically there's dopamine in this structure in your brain called the basal ganglia. And the dopamine helps the body move when it wants to and not move when it doesn't want to. So then the hypothesis is that when you have low iron levels, it messes up with your dopamine levels, which then impact the movement of your body. So in this case, you have that leg that you have to move, you feel that urge to move it. Another aspect is arrhythmias. So with anemia, you can have rapid heart rates, and not only can this be rapid, but it can also have an irregular rhythm. The other theory is that also because you have decreased oxygen carrying capacity of your blood, your heart will have to pump more or kind of work more to get that oxygen and blood volume to your cells. Similar to that, we also see extreme fatigue. So specifically, we have that lower oxygen delivery because if we don't have that iron, then you can't carry that oxygen with your red blood cells. So then less oxygen gets to cells, cells can't metabolize as well. And so you get that extreme fatigue and muscle weakness all throughout your body. So we can move on to the next one. So some treatment strategies are oral supplementation of iron, and there's also intravenous administration. So there are some similarities, and the similarity is that they're both trying to replenish the iron stores. Now, they're just doing it in different modalities. Specifically, oral supplements have been preferred because they're more accessible, especially in underserved regions as well. They're also much more cost effective. They're easier to use by patients. It also limits the risk of infusion related events. So as with anything, whenever you have an infusion, you can always get some sort of hypersensitivity and some sort of allergic reaction. One thing with oral supplements, though, as Matthew mentioned, prior meta-analyses have shown that oral supplements are actually increase the risk of adverse gastrointestinal effect. So as we can see, when compared to placebo, those getting oral supplements had a 2.32 times greater odds of developing these GI adverse events, specifically like nausea, vomiting, and so forth. Same thing with IV iron. So those who received IV iron had a bit lesser odds than getting GI compared to oral supplementation. Another aspect is that individuals with different GI malabsorption conditions, for instance, celiac disease, or individuals who can't absorb things very well through their gut, also won't be able to absorb this iron. So that's why oral supplements will not be indicated for those, perhaps. We also have intravenous administration. So this is somewhat quicker to replenish your iron stores. And this is especially preferred among those with ongoing bleeding and GI upset and so forth. This is actually associated with the lower frequency of blood transfusions. So that's a positive. Individuals who are getting this intravenous iron actually had a lower need for blood down the road. As you can tell, though, and as we discussed, you need that infrastructure to actually administer this iron intravenously. And there's also infusion reactions, which can cause, again, anaphylaxis, shock. And again, very rare, but it could also be fatal. So that's just the fact of weighing the options and depending on where the patient is and the condition of the patient. So we can move to the next one. Yeah, one more. Okay, so in terms of just to see what the cutoffs are, so as you can see on the screen, these are some of the cutoffs where how iron deficiency is defined in patients with heart failure. Now you may ask, well, why is this definition a little bit different than patients without heart failure? And the reason why is because with congestive heart failure and also with inflammation, there's a higher ferritin tissue expression and concentration in the peripheral blood. So you can't use the same cutoff as normal control, because then the patient might actually be having iron deficiency, but you're just not catching it. So this just goes back to the fact that with all guidelines and with all cutoffs, you really have to be mindful of the unique context and the unique comorbid conditions of the patient themselves. So that's just one thing to keep in mind.
So this is a definition I tend to use more and more. This is set up by the European Society of Cardiology, and they're saying that a ferritin level of less than 100 is considered iron deficiency. And you can see that in many other groups that, iron is normal to around 11, or ferritin is normal to around 11 in women and to about 22 in males. So it carries a different definition. And like as you point out, Kieran, is that congestive heart failure is an inflammatory disease process, lots of inflammation, and inflammation causes ferritin levels to go up. So we have to use a different cutoff. And as Matthew pointed out earlier as well, that transferrin saturation is important too as well. So that if your serum iron or ferritin, is less than 100, or your transferritin saturation between 100 and 300 is less than 20%, these are suggestions that you could be iron deficient. The problem is that between 40-60% of patients who have congestive heart failure carry this definition. And so I think we're still learning about that, and you're going to show us why that becomes important right now. So realize it's not just one set of numbers, there's multiple sets of numbers right now. And I'm still learning that more and more, but I certainly starting to use this more and more. Tell us more.
Right, so these are just some trials for iron infusion in heart failure. So the first trial is the AFFIRM trial. As you can see, over 1,000 patients. So those who got IV iron had reduced risk of heart failure hospitalizations. But as you can see with the risk ratio, it just missed the significance for reducing the risk of cardiovascular death. So yeah, we can see it's crossing 1, so that suggests no effect at the upper end. Now, then there was also the CONFIRM trial with over 300 patients. They also used IV iron, and this time we saw greater improvement in the 6-minute walk test, and also a reduction in the risk of heart failure related hospitalizations. So again, we can see with both of these trials, we have reduced risk of heart failure hospitalizations. Now, not mortality per se, but if we can reduce the risk of hospitalization, that could be a patient-important outcome. We also have another trial, this one over 450 patients. And again, we can see that the patient assessment and the New York Heart Association class was improved in patients who are getting this IV iron, irrespective of if they had anemia or if they did not have anemia. Regardless, if you gave them IV iron and they had heart failure, they still did better than placebo. So I guess this can again show you how did they define anemia. Perhaps again with the cutoff, if you use the normal cutoff, the patient might not have had anemia technically using those cutoffs. But if you use the heart failure cutoffs, perhaps they do have anemia. And again, that goes back to how do these trials classify patients and what cutoffs do they use. Now that's iron infusion. If we go to the next slide, we can also see oral iron repletion. So now this paper used oral iron. Now this one, over 200 patients, they studied a bunch of outcomes. And the things I want to highlight are in red boxes here. So they actually did not find a significant difference in the peak VO2 max. So this was an indicator of exercise tolerance. And as you can see, the p-value is not significant. And also if you can see the difference in change from baseline, we can see it's crossing 0 with a 95% confidence interval. Now, in the other paper, we saw the 6-minute walking distance. In this paper, we can again see oral iron versus placebo, not significant change in the 6-minute walk distance at 16 weeks post intervention. Another thing that we can mention that we actually discussed with Dr. Kearney was the Kansas City cardiomyopathy with the score. And again, the score here was also not significant at 16 weeks. Now, on the other side down here, it's not highlighted, but it's also worth mentioning that in terms of the safety endpoints, they didn't see any significant increase in adverse events, serious adverse events, or so forth. So what they concluded was that they didn't notice any significant benefit in terms of the outcomes, but also they did not see any significant risks either with this oral iron repletion therapy.
If you go back one more trial here, so they didn't. So to me, this is this argues that intravenous iron is the way we should think about it. It's expensive, number one, intravenous iron. Number two is that they only had 225 patients. They didn't try all that hard, only 16 weeks of therapy. So I don't think they optimized the way you can deliver oral iron at this point in time. So we're still learning about this. And there's certainly other bigger trials underway with intravenous iron therapy. So we're still learning about this. So, let's learn a little bit more, and we'll talk a little bit more about this as time goes on. Thank you for sharing that information. And very important is that we have different definitions of iron deficiency. And one of the things is that patients that had a normal hemoglobin who were iron deficiency by the criteria having a ferritin less than 300 with transferrin saturation less than 20% benefited, even though if their hemoglobin was normal. You feel still normal. So we're still, when you think you know everything, you still have a lot to learn. And that's why these webinars take a long time to understand that. Keep going, keep going. Next slide, please.
Okay, so I'm gonna actually take over here. We're looking at the lifestyle interventions for iron deficiency anemia. So we're gonna be touching on both diet and exercise and kind of just some of the tips that you can use to help. So next slide. So an anemia diet focuses on mainly iron-rich foods, but it's also important to consider those that are good sources of other nutrients. So we want to be looking at vitamin C, vitamin B12, and folic acid, and those have kind of already been discussed earlier in the webinar. It also discourages the consumption of some foods and beverages that impede iron absorption. I'm going to go through kind of more specific examples of these as we move on. So next slide. So this slide kind of summarizes those iron-rich foods, and it's very important kind of I've indicated a few in each kind of category, but there are many more. And if you do just a simple search of iron-rich foods, many will come up. So if we look at fruits and vegetables, things like kale, spinach, peppers, those are kind of the main ones. If you look at meat and fish, we have beef, lamb, salmon, most fish products. Nuts and seeds, again, you just see you have the pumpkin seeds, cashews, and a few others. And lastly, in the beans category, kind of all your beans. You got your black beans, pinto beans, and chickpeas. And so, yeah, so just take a note of maybe some of these foods. Let's move on to the next slide.
Well, hold on. This is actually important. I would take a picture of this if everybody is, one of the things is that people say I want to take less pills, and that we've shown that if you take iron pills, 70% of people will have some GI problems. It can lead to constipation, hard to use, but this is a great way of increasing the amount of iron in your blood. Also, too, as you point out, you take it with vitamin C, that actually boosts the effect, as you're going to show us in a few minutes from now. So this is something that I think is that I'm trying to get a lot of my nutrients through food, and we did a nice video on people should take vitamins and supplements, and most of the time the answer is no for most people. And this is very powerful. Mother Nature, the cocktail, the recipe, Mother Nature has it. We don't do as good a job as Mother Nature. Keep going, keep telling us more.
Yeah, so on the next slide, we're going to be kind of looking more at those foods to avoid. So we have tea and coffee, milk, and some of the other dairy products. We have foods that contain tannins, so those would include like grapes, corn, and sorghum. Foods that contain phthalates or phytic acid, so that's like brown rice or other whole grain wheat products. And then lastly, foods that contain oxalic acid, so you have peanuts, parsley, and chocolate. And again, so these are just some examples of foods to avoid. There are also longer lists online, but these are just some of the main ones.
So drink your coffee 30 minutes to an hour after your dinner. I make the mistake sometimes of having coffee all the time, and I'm preventing absorption of certain nutrients about this. So thank you for sharing that.
Yeah, so on the next slide, I've provided some sample meal plans. This is just from a website I found with just a couple options of those meals that would be higher in iron. It's also important to kind of maybe make sure that you are, as Dr. Kern just mentioned, kind of having that tea and coffee after, but not having them with these meals. So kind of that oatmeal with various different fruits, or even the bottom option with more meat. And then kind of moving over, we have the bowl of beef chili, again, with that meat in there, and the spinach salad, both foods with high iron content. And lastly, even moving into the dinner options, again, foods that are high in iron. So you have like the meat on top, and you have the beans on the bottom, which again, is very strong. Yeah, so moving on. we'll be touching more now on the exercise interventions. So on the slide, it's just kind of an overview, and then I'm going to provide a couple points for those with anemia that are looking to exercise. So regular physical exercise can lead to improvements in anemia. So most notably, this would be by helping to offset chronic fatigue. So endurance or aerobic exercises promote blood cell formation, a process known as hematopoiesis. So more blood cells would then increase the hemoglobin, and therefore you kind of want to choose activities that are aerobic and that you would enjoy and that you would actually want to do on a daily basis. So opportunities like walking, dancing, biking, and swimming, kind of these are some examples that are very good aerobic exercises, but obviously you can do them at your own pace. So if we move on, I'm just going to provide a couple tips that I found that have been suggested. So one thing when you have anemia is you want to really make sure you're starting off slow. So you start your workout slow and progressively increase the intensity over time. You don't want to start too fast, as this could ultimately actually have negative consequences. It's also important to take breaks often. So you want to make sure you're listening to your body. If you feel tired, you want to pause and assess, and you want to determine whether or not you want to continue, and really make sure that you're only doing what you can do. Next slide. Also shortening your workouts. So any amount of exercise is better than none. That is a very important thing to consider. This number here, 300 minutes of moderate exercise or 150 minutes of strenuous activity on a weekly basis provide greater health benefits, but this obviously can be spread out. You don't need to do that in 1 or 2 days, but kind of if you do a few 30 minutes, an hour every day, it'll obviously add up. And shorter workouts, as I mentioned before, such as walking around the block or climbing stairs, add up. And these will actually contribute to your weekly physical active goal. Next slide. And lastly, timing is key. So really, in order for somebody to exercise, you want to make sure it's at a good time for you. So whether you're a morning person, you want to get it done in the morning, or a night person, you have to make sure that that exercise that you're doing is helpful for you, and you actually want to be doing it, and you'll continue to do it because obviously it's very helpful. And lastly, you want to make sure that you're talking to a healthcare provider. So ensure your workout routine is safe. You obviously don't want to be overexerting yourself. You want to be making sure that it also ultimately is helping you. And you want to make sure that you are still sticking to your treatment plan that is already prescribed to you.
So we always have some references there. Is this our final slide?
Yep, we got 4 pages of references, but that's it.
All right, let's show some more references there. Okay. All right, so we're good people showing references there. So why don't you just go back a couple slides to go back one more here. This is something that we can stop here. So anemia is a complicated disorder. So here's what I learned today is that the way we initially diagnose anemia is looking at the hemoglobin. You can look at the hematocrit, but mostly look at the hemoglobin. And you can go back and look at what's normal for male, for females. As we get older, tends to fall. And one of the things that many of us, as we get older, we are somewhat anemic. And the question is when to go chasing after something. So, and what is the definition? We always worry about iron deficiency first, because if you're iron deficiency, sometimes you can be, it could be a cancer in your GI system that's causing that. So sometimes we have to look for a tumor, a cancer there. Many times we don't find that, but that's have to decide with your physician whether or not to look at that. And we carry different definitions. Now, because I treat a lot of people with congestive heart failure, the one I carry the most is that ferritin level less than 100 and a ferritin less than 200 with transferrin saturation less than 20%. But other doctors carry a different definition of iron deficiency, especially a young woman has a ferritin of 100 in a young 20-year-old lady is a pretty good ferritin level. And so that's something to think about, and what disease processes that you have. And there are numerous causes for this. And I think it's one of those things you have to look at. And one of the things is that go look at the webinar or what's in the blood. So make sure you understand that when you're getting your blood results, that you look them up and discuss that with your physician. I have both reservations and enthusiasm in measuring hemoglobin levels because it is so abnormal in so many people, and many times it's not clinically important. Other times it can be. So it's important that you actually know your number and be in charge of that. So causes could be anything from a cancer to bone marrow suppression to certain drugs that can do that, or even certain drugs can actually help improve that. Exercise is a great way of bringing up hemoglobin, improving your Kansas City questionnaire. If you want, exercise at altitude. I went to Kenya, and believe me, after coming back there, I did some running there. And when I came back, and in the first 2 weeks when I played squash, I was a super athlete because I had a higher hemoglobin because of being in a place that had low oxygen levels and being physically active. My hemoglobin came up, but within a few weeks back to North America, it fell back down to North American levels as well. So there's so many ways to think of that. I want to thank the entire team for putting this together. Any questions or comments from anybody out there? Any thoughts from some people there? Because I like this lifestyle issues, but also realize that if you take an iron pill, take your iron pill on an empty stomach. Take, let's say, ferrous gluconate, 200 milligrams a day, whatever iron pill that you choose. Take it on an empty stomach, and take either with an orange juice or vitamin C tablet to improve the absorption of iron. But I rather get my iron from natural foods and also diet that has vitamin C in there too. I have my orange and my other fruits and vegetables along with that. So that's how I choose to. I basically don't think vitamins are useful for the vast majority of us. Good nutritional food, and look at that video if you can on vitamins and micronutrients, how to do a better job of that. Certainly, if you're a vegan, you have a high probability of being B12 deficient. So you can certainly take fortified yeast, and you can certainly take nut milk that's fortified with vitamin B12. I learned if you drink too much alcohol, that prevents folate metabolism, and your folate deficiency can be quite common as well. So there's so many ways of looking at these sorts of things, and thank you for sharing that. I think you did an excellent job, and I learned a lot. Thank you so much. Questions or comments? Stuart, what's your thoughts about this? You have a headache?
I think I learned that anemia is a lot more complicated than what I initially thought. I guess I kind of had the assumption coming in that, anemia is iron deficiency. And as you pointed out, I can fix that with some iron supplements. But I've come to realize that there's not just iron deficiency anemia. There's so many other potential causes of it. And I think I just really recognize that, of course, you can have symptoms for anemia. You can also not have some symptoms of anemia. But many of the common symptoms that Matthew was touching upon when it comes to like shortness of breath, weakness, palpitations, things of that nature, of course, that can be anemia, but that can be so many other things as well. And so if you do have those types of symptoms, it's good, of course, then to have conversations with your family doctors, with your cardiologists, with your specialists, do some tests to see exactly what the potential causes are of these symptoms and what the best course of action is. Oftentimes, regardless of what the diagnosis is, it's never a bad idea to engage with a healthy diet and engage with regular exercise as well. So while we did talk about exercise and diet in the context of anemia, I think we could all learn a thing or two from this webinar in terms of what are some of the things we can integrate into our diet on a weekly basis and how we can also be healthier by integrating exercise into our lives more regularly. So anemia is very complex, absolutely. Having conversations with your doctor is important, and trying to be healthier every single day is kind of the takeaway I have for this webinar.
Yeah, wonderfully said. So, if maybe my restless legs, my aches and pains in my legs, not my cholesterol pill, it's just I'm iron deficient. Maybe my fatigue and weakness could be you're anemic, but more likely if I smoke, I have congestive heart failure, COPD, I'm deconditioned, I haven't exercised, my kidneys don't work. You can see all sorts of reasons why you could be short of breaths, and you can see it's one factor of that. And the excitement right now is that we're now looking at iron infusion as a treatment for congestive heart failure to prevent or delay congestive heart failure admissions, but we still have a lot more to learn. And I'm gonna tonight. I had some nice vegetable soup and a nice salad bowl. rich in vitamin C and rich in folate, B12. Actually, not B12 tonight. I didn't have any fish or meat products and I put my coffee aside. So I got to remember to do that and just drink water during those times. So I want to thank the entire team. I hope people take advantage of this and learn if this is something that's important to yourself. It's a common problem. Sometimes it's clinically important, sometimes it's not, and that only you and your discussions with your healthcare team can sort this out for yourself. So we're going to bid you all a good night, and have a great night, everybody.
Have a good night, everyone. Take care.